David, thank you very much. And again, it's a great pleasure to be here, and I'm delighted to see that Bristol has reached this point in your own journey. And as David said, I'm going to talk about the academic component of this partnership, recognising that what David has described is a partnership founded on the principle that bringing people together to effect population health gain is the galvanising force behind all that we do. But how does academia benefit from that framework, if I can put it like that, draw on the strength of this partnership to enable discovery, innovation and its translation to occur? First thing to say is that we are committed to the whole of the translational pathway, from fundamental science through to population health gain. Any academic in this room will appreciate that research is not something that can be mandated or managed or directed. It's a creative process. And this is particularly true when you try and achieve research across a broad partnership involving many institutions, as in our particular case, and I believe as in yours. What you can do, however, is facilitate overcoming the barriers to this translational pathway. So in my role as academic director, I see it as one of achieving that facilitation, bringing the partnership together and addressing what we might do to overcome gap one, discovery to proof of concept. What things might we do to help bridge that particular area? And then secondly, what might we do to achieve the closure of gap two? UCL Partners provides the context and the framework, the population access and the ability to impact on that broader population through our research. So let's think briefly about gap one. We're very fortunate in having strong life sciences, and we've got the emergent Francis Crick Institute, which will be the biggest biomedical research centre in Europe. We have a panoply of biomedical research centres and units driving experimental medicine, and we have a growing number of true industrial partnerships co-developing new therapeutic approaches. And the sorts of things that we do to encourage closure of this gap are, for example, enabling non-clinical life scientists and biomedical scientists to understand better the clinical need and the nature of disease, so that they're not the handmaiden to a clinician scientist. They're actually empowered to take things forward on their own. We can encourage academic industrial exchange to break down the cultural barriers between those two sectors. What about gaps 2 and gaps 3? Gaps 2, trials and then their implementation of their results. We're a pilot site for incorporating the comprehensive research network within our academic health science network to get that alignment of purpose, as well as creating harmonisation of approval across this broad partnership to really enable us to build scale in terms of the trial subjects, get everybody involved as a research participant. That needs to be underpinned by the intellectual capacity of new methodology in clinical trial design, and we're forming at UCL an Institute of Clinical Trials incorporating the MRC Clinical Trials Unit. This will provide a bedrock of some 300 methodologists involved in clinical trials. We're bidding for a clerk to drive the improvement science, the diffusion and adoption to underpin that particular phase. And then I always state that the final barrier to evidence-based practice is the patient, the citizen themselves. And so very, very important is our emphasis on understanding health-related behaviour, what matters to people, so that we can achieve treatment optimisation, the best adherence to evidence-based practice that is possible. Now, it's often the case that when we think of academic health science centres, we have a narrow concept in our mind of life sciences and biomedical research. I would say that if you're going to address the whole of the innovation pipeline from conception of clinical need through to understanding what is tractable, to understanding how you move new developments faster through the process of licensing, commissioning, and ultimately adoption and diffusion and adherence, you need the whole range of academic disciplines which a multi-faculty university or universities will embrace. So we formed a centre for sustainable medical innovation with the University of Oxford, CASME, which you can look up on the website, which is addressing all of the issues on this cycle, understanding that innovation has to be approached holistically if we're going to do what patients want, which is to get new treatments to address unmet clinical need to them faster, and ones that really address that unmet need. So let me finish by a brief description of one opportunity and one particular challenge. The challenge is that clearly the partnership focused on achieving population health gain has to be inclusive from a healthcare pathway perspective. Everybody has to be involved, all partners in that healthcare journey. Research is not as an inclusive a process. It is, of course, inclusive in terms of engaging with patients and the relevant disciplines for wherever they come. But if you involve every part of every university with which we're involved, you will not get world-class science. So it's about the partnership being honest within itself and say that top-class research needs to draw on the relevant skills for the particular problem in mind. The opportunity, I would suggest to you, through this societal, this population link and the breadth of the partnership, is what I term reverse translation, which essentially means drawing on the population health studies, the understanding of epidemiology, the understanding of the outcomes of your innovation to inform what the next challenge is, to inform the basic discovery science that needs to be effected to make the next jump in the innovation chain. You will only achieve that, as Pam said earlier and John Kerwin said earlier, if you have genuine public and patient involvement in this whole research endeavour. So I would absolutely endorse the centrality of that and how important it is that you approach that in a very genuine fashion. Finally, what do I see as the key enablers of this academic enterprise that's part of UCL Partners? Absolutely central, not only to the academic endeavour, but actually also the clinical endeavour, are informatics, born of strong metrics. And it's the most common thing that comes up as amongst our challenges and the things we need to address, and the thing that would enable us to make faster progress if we had that comprehensive access to information, the safe haven to protect patient confidentiality, and being able to collate all the various sources of data that impinge on the research questions and the healthcare questions. We're fortunate of having our partnership having been chosen as one of the centres for the e-health informatics research, so this provides a capacity for us to begin to develop the answers. And the second most important enabler is the one that David referred to, which is the culture, a genuine culture of collaboration and partnership, which is central to the whole endeavour. I'll stop there. Thank you.